With so much Botox filler coming up, very difficult to know the age of anyone, right?
Shubhra, please.
Very good afternoon. So thank you, Devraj, for inviting me for this exciting session. My job has been made simple by Shilpa because she covered the anatomy in quite a detail. These are my financial disclosures. Now, whenever we talk about Botox or fillers, nowadays, because it's kind of become like, the talk of the town, everybody feels it's pretty simple. You can just stand in front of the mirror. What is there? Just some some injection in a syringe and you have to inject. Now, this is not as simple as we think. The reason being, the facial anatomy is pretty complex. It takes a lot of effort and a lot of learning before you can become the safe injectors, because every inch of your face or quarter of your face is potential danger area when we are injecting either Botox or fillers. So the paramount important thing is that we need to have our anatomy very, very thorough before we start injecting on patients. Now, botulinum toxin has been known to us as a sausage poison, and it has been used in strabismus surgeries, and that's how it got into action in cosmetic indications. And it was only in 2002 when it was FDA approved for the indication of glabular rhytides or linkles, or we call as the anger lines. We know that botulinum toxin is used on the face or around the eyes for a lot of functional indications like blepharospasm, hemifacial spasm, and so on and so forth. But now we have reached an era where we can practically do a full face rejuvenation, modulation, and recontouring with the use of combination of botulinum toxin and fillers, and it can practically use from top to bottom and ear to ear as indications. So my role is very limited because we are just talking about periocular botulinum toxin. I'm not going to go into the lower face and the advanced indications as of today. The botulinum toxin is available in different strains from A to G. It's only A and B which is therapeutically and medically indicated and has been in used. The type A is known by Botox and is manufactured by company Allergan, and there are other type A Botox in the market as well. One of them is Dysport and Xeonim. Myoblock is not been approved for cosmetic indications as of now, and we don't even use it. So it's practically type A which will be put in use when we are using for cosmetic indications. Before we start, it is important to understand the pharmacology and the pharmacodynamics of the product, because what you have in your hand is actually a poison. So if you don't know what it contains and how you need to use it, the same drug can cause some unwanted reactions or complications. So it comes as a lyophilized powder in a bottle. The bottle actually looks a little empty. If some of you were in SSTC yesterday, we had shown. And then it is reconstituted, because unless we reconstitute, the action of the botulinum toxin will not start. It is reconstituted with preserved or unpreserved normal saline. Reports have shown that it doesn't really matter whether you're using preserved or unpreserved. The pH and the efficacy remains the same. Now, before you reconstitute, it has to be supplied to you by a registered distributor of Allergan. Please make a note, registered distributor of an Allergan, and it has to be maintained in a cold chain. If the cold chain is not maintained and it is not handed over to you in a proper manner, you can actually return it back to the distributor and ask for a new bottle. Before it's reconstituted, you can put it in the refrigerator, in the freezer. That is what is indicated. But after you reconstitute, it has to be put at 4 to 8 degrees Celsius. Now, the guidelines as per the Indian industry is that you have to use it within 24 hours. That's a guidelines. But in practicality, we have kept it up to 4 to 6 weeks, and the longevity and efficacy does not get affected. And now there are papers to actually support it. So this is what you need to do once you have reconstituted. The reconstitution can be done with different different nomograms. The key is you don't want a botulinum toxin which is reconstituted in a very, very diluted manner. You want something which is concentrated, because there's something called circle of diffusion, which is around 1.5 to 2 centimeters square, and you don't want to use too much of product in an area for diffusion, right? So you need a concentrated product which stays where it is supposed to stay and produces action. So the optimal dose which we use normally is 2.5 ml, which will make it as 4 units in a 100 unit vial. Now, before you start injecting, it is of important it is very important to understand the facial aesthetic features of men and women and people coming from different parts of our country. Our country is blessed with different ethnicity of people. If I go down south, people want heavier faces. If I go to the north, people want sculpted faces. So it is depending upon what background the person is coming and what kind of genicity they have that you have to produce or maintain those features. Now there are consensus on Indian population which have been recently published in PRS. It's an open access journal. You can download the article and go through it. It covers in detail about the average dosages which have to be used for different indications of botulinum toxin and fillers, and how and where you should be using, and what is the priority areas which can be injected. Now the checklist is very simple. As in any other procedure, you want to have a medical history of the patient. You want to make sure the patient is not suffering from anything which is contradictory to botulinum toxin, like any neuromuscular disorder. You want to make sure patients are not on any anticoagulants, and you want to stop it at least 3 to 5 days in advance, and you prepare the patient for the procedure. Counseling makes a paramount importance. You have to spend some time talking to your patient, listening to your patient. It is not like cataract surgery where patient needs it. It is an elective procedure. You have to make the patient comfortable to get the procedure done. So there would be certain concerns before and after or during the procedure which you need to answer with a lot of patience. There could be some questions like, you know, I have a fear of complication, or what if the results are not what I'm expecting? And if you saw yesterday in SSTC, as soon as the needle was coming closer to the face, even, you know, a doctor patient would get scared. So you need to counsel and prepare the patient. You have to have your tools handy. You have to have the trolley ready, preparation trolley ready. You have to keep the consent forms ready and take a proper consent and document it with photography in all the gazes, which is front, profile, lateral, with expression and without expression. And I'm just going to skip this very quick because Shilpa has already covered this, but I'm just going to stress on the point that whenever you are injecting, it is not into the wrinkle, it is into the muscle mass, because it's muscle which is causing the wrinkle, and the wrinkle is always perpendicular to the action of the muscle. So if you know your anatomy, frontalis is the elevator of brow, and that's why you get horizontal wrinkles. The glabella is the depressor of the brow. The procerus and corrugator is the depressor of brow, and that's why you get a vertical wrinkle. So this is what we need to understand before we start injecting. And obviously orbicularis oculi, I'm sure you all know, it has a palpebral, tarsal and an orbital part, and we are focusing on the orbital orbicularis muscle which is causing the crow's feet. Now when you're injecting, as I said, why the consensus have been taken out is for this reason only, like no face is same. Okay, even one half of the face is not similar to the other half of our face. So you cannot really standardize something and say, I will use 4 units and 8 units and I'll give so and so points. Yes, there are some standard points and standard dosages which have been taken out based on consensus, but you have to tailor-made it according to patient requirement. Now these video sources are from Allergan for the simple reason because I wanted to show something which is standardized and not what I do, because here we are trying to tell the basic standard technique of injection. So what we have to do is, once you have prepared the patient, you mark the areas where it has to be injected by asking the patient to animate repeatedly. As I said, you're going to inject into the muscle and not into the wrinkle. So once the patient is animating, you know where the maximum muscle mass is. Your depth of injection, as we have been discussing, is subacute and not into the muscle per se, because your muscle is practically adherent to the skin. You're not going to hit the bone and you're not going to cause the pain to the patient, because Botox injections are never given deep. So this is what the patient could achieve after pre and post, and a red flag area is that you have to stay at least 2 cm above the orbital rim or the brow area, because we know frontalis is an elevator of brow and we don't want to go down and bring the brows down. So we have to play around the agonist and the antagonist muscles of the forehead. Now coming to the glabella area. So one more word on spock deformity. This happens basically because you're not targeting the depressors of the brow or the medial depressors of the brow, which is corrugator and procerus. You have paralyzed or created a paresis of the central frontalis muscle, and you're still letting the lateral frontalis muscle to act, and that's how you get this spock deformity. So if you have this deformity, you can inject a tiny bit over the area where the maximum pull of the frontalis muscle is there and can relax it. The other way of doing it is that you target the lateral frontalis muscle, which usually in some cases we land up not doing, and hence you will not get this Now coming to the procedures and corrugator, just a trick here is you have to understand the anatomy of corrugator, which has a deep and a superficial head. Procedures is very easy peasy. It is in the central muscle. It is pretty superficial. You can pinch it between your hand. If you can hold between your eyebrows, you can actually feel the muscle. Once you feel the muscle mass, you can inject directly into the subacute area. However, the corrugator, because it has two heads, you have to target the heads. When you go to the deep head, which is here, you have to go up to the hub of the needle, because if you stay superficial, you're not actually targeting the deep head. And you have to ask the patient to actually frown and see where the dimpling effect happens, and that's the insertion of your corrugator as superficial head in the dermis, and that is where we are going to inject superficially. Do I have like few minutes to continue? Yeah. So these are some of the pre and post. And on injecting of orbicularis, now every patient would have a different kind of crow's feet. Some would have a single line, some would have a double line, some would have a full fan. So once you ask the patient to animate and smile, you would know the extent of the crow's feet till where it is extending. Now there are 1 point, 2 point, 3 point techniques. As I said, I would please recommend you to go through the paper, because every consensus paper would tell you what is the optimal dose and optimal position of injecting. But the key here is that you stay on the lateral orbital rim, towards the outer side of the lateral orbital rim, and not towards the globe, because we are targeting the orbital fibers of the orbicularis. Your needle has to stay away from the globe. Not that it will cause anything if you are directing it towards the globe, but it is always a safe procedure to stay away. A word on zygomaticus major, which Shilpa also touched upon. A lot of patients who are over-injected or injected way down chasing the crow's feet would come with a funny smile or a gummy smile or a flattening of a cheek mound, which is not so aesthetically appealing. And this happens because your zygomaticus major actually is a major cheek elevator which goes up to the lip and is in a continuum of your orbicularis oculi. So never chase the crow's feet, just treat the muscle, and as I said, you're targeting the muscle and not the wrinkles. Chemical brow lift, once you understand the agonist and antagonist of the brows, is very easy. We are targeting the lateral orbital fibers, orbicularis fibers, and also the glabella and the procedures. So again, a small video on, you mark yourself and say that you're going to stay lateral. You remind yourself that you're not going to cross the supraorbital and supratrochlear area, and then you simulate where the maximum height of the brow has to be produced. Now, botulinum toxin cannot cause a lot of brow lift. It only reshapes the brow to create an arch. If you need a lifting effect, it is to be done by dermal fillers, because fillers is something which volumizes, and botulinum toxin is something which is working on the muscles. So I think Dr. Kasturi will also talk about it on her filler talk. So you are just creating a shape of the brow by injecting the botulinum toxin. And this is how you can actually change the look of a patient and kind of give a little bit of elevated look. Some of the expanded indications we have been talking about it is inferior orbicularis hypertrophy, which is pre-tarsal. We can just iron it out. This patient was taken for fillers before, maintained the fillers, but came back with the orbicularis hypertrophy of years, and that could be ironed.